Right, welcome, and over to you, Ricky.
Thank you for that. Yeah. Oh, that was just it was disabled, the microphone there. Okay. Um, so I think it's really important at this stage to just give a little bit of a background from where this is. This is such a really big project that was really the identity of the communities team within the service within the service sphere. And when our at the time director of public health, Justin Varney, came up with this idea, it was really a big thing that we had no idea of how we were going to get this done. So there was many iterations of the community health profiles that started, many discussions, and just a big thank you to those people who have worked within my team on this and those people who have moved on to other pastures. They've all contributed to this, and to do something at this scale is absolutely brilliant. So I just wanted to say that from the forefront. It's not just me. It was everybody else that's kind of involved. Just give me 1 second, yeah. I think it's ours. Sorry about that. I was going to get in trouble if I didn't open that door. Okay, so just going to give you a little bit of background in terms of how what the makeup of it was like. So just kind of going back to COVID times, where the whole profile story had started. And as we did the first iterations, we just didn't know how to kind of set it, what kind of structure, what kind of methodology would look at it, what kind of story that it was going to be able to tell of communities. And at the time, we came up with a few communities that we were going to be sort of concentrating on. But the theme, like I said before, was massive. And we took that from the Greater Boulder Healthier City strategy around it. So it had 10 themes within there. So think about it from sort of cradle to grave, was the sort of theme. But within there was getting the best start in life, having mental well balance, working and living well, and vaccination and etc. came in a little bit later on down the line with some of the other projects. So we had to, even though we were writing them down and getting them commissioned out, we had to keep revising it to add the extra sections that were coming in, because COVID actually proved why this was so important, that stories of communities were being told by data, but not just what was being found, but what were the gaps in that data. So we broke it down further then. So I'm on slide 4 now, if that's if for you guys. Originally, it was going to be sort of 4 areas that we were looking at, which was around ethnicity, disability, religion and faith, and sexual orientation within there. When the Commonwealth Games was around, I think that's when the other parts came in around regional communities and other. And it's really important to kind of get that in at this stage. So one of the first two profiles that we did was with the Sikh community, and there was me coming from that community, I was able to kind of have a little bit of a nuance and understand it as well. I have other interests outside of work, so I was really sort of involved to see what the story of the data would actually say. And it was really important that we also kind of established and understood some of the cultural aspects of communities as well. And that is a nuance that gets missed within data as well. So in total, there are 25 profiles, and like I said before, we started with two, and the Bangladeshi profile was really also important because we were incorporating some of the work that was being done in our creative arts and health sort of stream as well. So it was and that was developing. So, given the backstory, we were new coming to this. Mistakes were going to be made, but we had a really open philosophy of saying that's fine, we're going to keep trying, and if we fall, we're going to fall forward, which I think is really, really important around it. So next slide, which should say key data sources. Now, we, as a team and as public health, we came up with the decision, obviously, to kind of use the data from published data that was already out there. So a lot of the data sets that were being used within public health were already kind of publicly available, and also from having sort of good engagement with communities. Sometimes one of the other tensions that you can have is that if you involve co-production from the start, you can then say alienate another part of that community because they just don't, some organizations don't get on, and there's just various different things. So we kind of went away from that and we said, okay, so what's the data out there telling the story of that community? And you'll see, and our colleagues will go into it a little bit later on, but it was published data that was readily available out there. We then moved on in terms of once the profiles had come in, we then identified and brought the community back in at that stage. What we put out was some tenders, which were allowing our engagement partners at the time to kind of come in, identify three inequalities within those profiles, and then almost kind of like a Kickstarter program, see what kind of health campaign that they can get from it to try and combat it. And most importantly, see whether the profiles that we use were being shared and how they are being operated with. So that was really the most important things. Many a time, and you'll see maybe within your own workplaces, that when people publish really good sets of work, it actually just gets left on a shelf and it never goes anywhere. So this was a real big thing in terms of how we were going to disseminate these findings, understanding partners. And so that's why we had a 12-month project. But also for those, we were dealing with some of the findings with such deep intersectionality of data and communities within those regions that some organizations didn't even exist. So what I would kind of get in pretty early, that I feel we're very proud that we know that we have been a reason why some organizations have come to fruition, or new parts of organizations have come up because of this work. So it's a really, really good thing. The only couple of bits where we had on that very subject were with the Pakistani and Indian engagement partners, we struggled to get an engagement partner, so we had to go out again a good few times. And then what we ended up doing was actually commissioning smaller contracts, which was more topic specific, which went really, really well for us as well. So hopefully at that point, I've kind of given you an idea in terms of what it was all about as well at that time. So understanding the dynamic nature of when the profiles were first thought of and where they were going, but also the kind of vision in terms of what we had. It hadn't, from what we had seen, it hadn't been done to this scale before. We had seen very small examples, maybe of just kind of one community or maybe a couple, but never at the size of 25 from our knowledge in terms from Birmingham Public Health. But most important of all, it's around the evaluation as well. So what we kind of done now, so I'm on slide 8, and then I'll be passing over to the colleagues here on the call. Was breaking it down into kind of 3 sections in terms of what the evaluation would look like. So capturing how the profiles are being shared, and see if it could be demonstrated regarding kind of decision making. Learning in terms of, for us as public health and the communities team, around building up more effective kind of engagement plans and for future profiles, as this is kind of a rolling project, but also in lining in terms of, this is what the data in the profile was telling the story of that community, but the gaps is probably more important, is what are we able to do to kind of prioritize or influence future data collection with our other partners and communities to say that those who are underrepresented. So I'm going to kind of pass over at this point and join you guys a little bit later on, in terms of after our colleagues over here will give their presentation. So, yep, I'll pass it over to you now.
Thanks, Ricky. So I'll pick up now and talk about the independent evaluation that we were commissioned to conduct, evaluating the community health profiles. My name is Dr. Laura Kudrina. I'm an assistant professor in health research methods at the University of Birmingham in the Department of Applied Health Sciences, also working at London School of Economics Consulting. And my colleague, Dr. Layla Aladou, who led this project, is a research fellow in the same, and will be co-presenting today. Before I go on to the details of the methodology, to pick up on the aims that Ricky discussed, I say we were really interested in this project because the community health profiles can be thought of as an innovation that is being implemented. And there's a very wide literature on the implementation of many different types of innovations throughout public health and different aspects of healthcare. And we wanted to find out not just what the characteristics of the innovation, the community health profiles themselves were, but also what were the characteristics of kind of effective implementation processes that would affect the use of the community health profiles. And I'll talk about a framework a little bit later on that we use to do that. Our overall aim was to understand how different stakeholders perceived the community health profiles and their use and implementation, what made it easy or hard to use them or not, and why. And we spoke with both users and non-users. I'll hand over to Layla now to talk about the methods itself.
Hi, everyone. Thank you very much for today. I can see a lot of familiar names and faces. I think I've spoken to most of you on this project, and thank you for engaging with me. So we decided to use the qualitative research approach, looking at the research aims that was given to us. And we utilized interviews and focus group discussions. So you can tell that I spoke to some of you one-on-one, and then I did speak to some of you as a group as well. Laura was talking about this before. So our approach was informed by the Consolidated Framework for Implementation Research, which she's going to talk a bit more into detail in the next slide about how that was used. Our sample size. So initially we had sample size for the different groups of people we were going to talk to, but then we used we got to a point of thematic saturation. So at a point where we realized no new data was coming up, so we stopped the data collection. We did our data analysis was using thematic analysis. If you're part of this study, you could see that most of our interviews were recorded and it was transcribed directly on Microsoft Teams. So that's what we used, and then we supplemented it with field notes. So with our focus group, we had like a second researcher who would be taking notes as well. So we used that to supplement our analysis. And this whole project was given ethical approval by the University of Birmingham.
So guiding our data collection and analysis was the CFR, or the Consolidated Framework for Implementation Research, as mentioned. And as Ricky said, it's so common for innovations like the community health profiles to be developed, but then just simply sit on the shelf. And therefore, although we wanted to look at the different characteristics of the community health profiles in terms of the innovation, so how it was designed, the different languages and communities represented, we also wanted to look at the other things that might affect whether or not it was used beyond the characteristics of the CHPs themselves. What were characteristics in kind of the outer setting, wider political and economic contexts? Think about things like austerity or funding climates that might affect whether or not these are used. Things within the inner setting at the council that could affect their use, such as changes in culture, leadership, or resources that could impact whether or not the CHPs are used in practice. The characteristics of individuals within inner and outer settings, their confidence, knowledge, and skills in using the community health profiles. Do they know about them? Are there opportunities to use them? Are they motivated to use them? And finally, thinking about the processes of implementation, things that kickstart the use of CHPs initially in terms of planning and judgment and execution involved in adapting CHPs into practice. This is a visualization of the CFR that can be accessed elsewhere. It's a very common way of representing all of the different complexities of implementation processes and the innovation itself. You can see on the right that there's the thing that's being implemented. This is the community health profiles. So we wanted to find out about the CHPs themselves, but we also wanted to find out about all of the other things that might affect whether they're used beyond the characteristics of the CHPs. So on the upper right, thinking about the implementation processes, who's involved again in kickstarting their use, is there any tailoring that occurs? Who are the individuals in the inner council and wider outer settings that are making decisions about their use and how they are used? And how do these things all fit together as well?
Okay, so our sampling, who do we speak to? Who was engaged in a focus group discussion? We used these people that had been involved in the developing the CHPs and users as well. So first, we spoke to users. Why did we have to speak to users? Because they have received the CHPs and they were using it in different ways. So we wanted to understand what are some of the ways that they use it and how best, how did they find the use of it? How best can we make it easier for them to use it? We also spoke to non-users. You might be asking yourself, why non-users? Because it's very important. One of the aims by the City Council was to make it accessible and usable to everyone. So we spoke to people that would have used it or would use it, but might not have been aware of it, or perhaps they were aware of it, but did not see it suitable, to understand why they think these were not suitable for them and how do we make it suitable for them. We also spoke to engagement partners. So engagement partners were commissioned by the Birmingham City Council, and they were involved in different aspects of the profiles. We spoke to them about how they were engaged and what are some of the challenges and what they thought about the profiles themselves. We spoke to policymakers and decision makers as well. And these were people that influence health and well-being in Birmingham. We wanted to find out about their thoughts about the profiles. Then we spoke to authors and writers of the profiles as well. It will surprise you to know the opinions that authors and the writers had on the profiles and how best we could improve on it. So after data collection, these were the participants that we spoke to, the numbers. So we spoke to 7 users, 4 non-users. We had a focus group discussion with 12 writers. We had a focus group discussion with 6 engagement partners, and we had a one-on-one interview with 5 policymakers. So spoke to a total of 34 people, you know. So first, I'm going to talk about the findings, but as Laura presented the consolidated framework for implementation research diagram, you saw about the thing, which is the innovation, and in this instance, the community health profiles. So we're going to talk about the aspect of this CFA that talks about complexity and adaptability. You might be wondering what it means. When we talk about the innovation complexity, it talks about how complicated the innovation is, and this is reflected by its nature, the number of connections or steps in the innovation. When we talk about adaptability, it talks about how the innovation, and in this instance, the community health profiles, can be modified, tailored, or refined to fit the local context. So most of our participants that we spoke to, so interestingly, when we're doing our data analysis, we kind of saw themes that cut across users, writers, engagement partners, policymakers, and some of these themes that are the ones that we are presenting now. They talked about how unique and tailored the CHPs were. So the first code is from a user that from the NHS, and they use it to gain knowledge about the different communities. They felt that the community health profiles had large documents, but then the City Council had gone in to do infographics and smaller summaries, which they felt very useful because reading long documents could be boring and it would not allow a lot of people to try and access it. But the infographics and the summaries were helpful to them to give them an idea, especially when you are trying to find a quick idea about what a community looks like or feels like. And also, they talked about the fact that their community health profiles had been tailored to specific communities. So you realize that sometimes communities are put into groups. So we talk about the Black community, we talk about the Asian community, but then the Black community comprises a lot. We have even the Caribbean, there's a lot, the Jamaicans, the St. Kitts, the Africans, we've got the Nigerians, the Ghanaians. So they were happy that the profiles were doing the segregation, like looking at it from different points, not adding them together. And also, we talked about the relative advantage of the profile, which means is the innovation better than the other ones available. So we had a user, a public health consultant, that saw that it was more useful than and accessible compared to census data, because if anybody has tried to access the census data, if you want to get information about a particular community, you'd have to go through different points, different areas to get everything. But then the CHPs gives you everything at one place. So if you want to understand how the Bangladeshi community looks like and health factors and everything, you'd find everything, and then you found that to be very useful. And another aspect of the CIFA framework is on the innovation, the CHPs itself was the design. So how did users see the design? Is it well designed, packaged? Has it been assembled well or presented well? So a user talked about it being simple and very simple to navigate. And also, they talked about how easy it was to read, especially with the summaries and then the infographics, and they felt that it was enjoyable. They also talked about the adaptability of it. So adaptability, as I said earlier, is how it can be modified or tailored or refined to fit the local context. So there was a concern of the desire to keep them updated because it would be useful to see an updated version or a way where the CHPs keep reflecting the current state of the communities that it's talking about. I'll pass it on to Laura to go into more details about the different aspects of the CIFA.
Thank you, Layla. So we've just been talking about the innovation, the CHPs down there on the right in the green box. And now I'm going to talk about some of the findings that we had from elsewhere that affect the implementation of the health profiles. So one of the findings that we had was about the process of the implementation. So the things that can kickstart whether or not the CHPs are used in practice. And one of these was around the role of co-production and co-creation earlier on in the process as facilitating dissemination later on in the process. And the intention of the community health profiles, as Ricky said, was to have a desktop exercise initially to look at the data that could be available about the different communities. But when it came time to disseminate, one of these writers was reflecting that it would have been helpful to have buy-in from different kinds of stakeholders right from the start. You might think, oh, it'd be important to involve the different communities themselves, for example, Bangladeshi or Sikh communities. And yes, that is what some people said, but they also said how important it is from the outset to work with, for example, other data teams, so the governance team within public health, and also the wider city observatory team as well. So considering kind of earlier on buy-in from different stakeholders. Moving on then from thinking about the processes to thinking about the inner and outer settings and the individuals within these. When we spoke with non-users, by and large, what they said was, I didn't know about the CHPs, but now that I do, I think that they would be something that would be helpful and interesting to use. And this is really related to psychological capability within the Consolidated Framework for Implementation Research, which is about the knowledge and skills that people have in order to implement the innovation. In here, you can hear and read a medical practitioner. I'm talking about the CHPs and how they could potentially be useful. Although they have more public health kind of information, they're saying, the CHPs might be useful specifically for research and also health needs assessments. And that's something that they would have found valuable now that they know about them. So certainly doing more work in order to ensure that they're in the hands of people who are knowledge users. Thinking about the outer setting as well and the importance of wider partnerships and connections. This is important from the perspective of ensuring that the innovation is adopted in kind of the wider networks beyond the council. And this user who was working within the NHS talked about how valuable it was to see the community health profiles presented on the public webinars, to have a follow-up conversation with the city council to really build those links, and to have bespoke and tailored sessions, which of course is part of the implementation process as well, in order to really solidify that wider partnership and connection between the council and the NHS. And in this case, they really wanted to have a focus on the healthcare of women and children, which the council was able to provide. So it's solidifying those wider partnerships and connections, really thinking beyond even, how the CHPs are designed and what they look like was something that was really important.
Okay, so this is a summary of our recommendations and speaking to most of you. So we saw that co-production and co-creation was something that was really important and would be useful in future productions of CHP moving forward. Another concern was about the CHP and how it was presented, that they felt that if they could have a more interactive platform or sort of a dashboard where users could move from probably one community to the other, trying to see same or similarities and stuff like that. So incorporating interactive elements in presenting the profiles was seen to be very useful, and it's a recommendation from the evaluation. And also dissemination plan. So talking to most of the users and engagement partners, they saw that having a clear-cut dissemination plan would have been very good. So some people that we spoke to, especially from the medical field, suggested using regular communication pathways when it comes to people in the NHS or the medical field. And they give examples like going through health professionals through their ICBs, how they communicate with them. Like researchers and people in academia would have preferred to hear about the CHPs from probably their research groups or from platforms like LinkedIn or X, or the different university groups. There was also the suggestion on moving, adding to desktop research. So perhaps doing their own sort of data collection to add to it, combining with qualitative insights from community engagement, moving from descriptive data more into looking at bigger data sets and different aspects to join in the desktop research that the City Council has already done, that would help to give a better insight into communities. These are some of the recommendations that came from the evaluation.
In terms of next steps, we will be working these results into an academic publication. We will also be feeding back to those who participated in this research, including those in attendance at this event. Thank you very much. We'll also be presenting them at the University of Birmingham Centre for Urban Wellbeing Away Day tomorrow, which anyone is welcome to join virtually. And I think my colleagues can drop the link to that in the chat. We'll also be working with Birmingham City Council and others to support actioning the recommendations and findings where appropriate, which I understand the City Council have already started to do. I must say Birmingham City Council have been incredibly proactive in actioning any recommendations in the data as they emerged. I think that's very impressive, and I'll hand over to Ricky to talk about that in a bit more detail. Over to you, Ricky.
Thank you for that. And you know, it's quite it's a very strange feeling to hear about the projects and seeing it through different kind of lenses as well, because obviously when you're working on projects, you can get quite fixated within it. I think just in some of the bits that were raised, I think it was really important for us to give a little bit of details that came through. And one of the things that came out was around kind of the leadership and with our stakeholders. And so within the city council of today is completely different to what it was last week, let alone what it was when this was happening. So when we have engaged stakeholders and making people aware of the community health profiles as it was coming through, that message might not trickle down with changes within their own systems and staff and boards being developed and going away. We revised looking at the new census data and adding that into the profiles as well. The co-production aspect of it, which we kind of explained at the start, was the premise of why we did it, was not involving the community at that point. It was later on. And where we have seen the dissemination plans is a kind of a wider issue within the council in terms of how it integrates and links in with citizens and stakeholders, which we will probably see a lot better now moving forward. So even for us, we're restricted in the ways that how we can do it. But one of the big positives that we have seen is when communities are putting in bids and tenders for opportunities that we have at public health, using our community health profiles as some of the foundation evidence base for why they're putting those bids in and some of those initiatives that they're coming through. And that has been, you go into other sort of conferences and you're hearing people quoting them, and in some cases trying to claim that they did them, which is a really nice kind of thing to take away, which is, it's a positive thing. But also one aspect from a skill set, which from our public health team and especially the communities team, where they've developed, as we've had new people coming into the team as well, for them to kind of learn this approach, learn this sort of innovation, and learn understanding data and moving through. It's been a real challenge and something really satisfying as a manager to see some of the staff go into this and move beyond it and utilize some of this knowledge in other areas of work. So the Blatcher work that has been done, the creative arts work that's been done, and the next steps which we're going to go through now, which is the deep engagement partner. So in true kind of Justin Varney fashion, as we were doing this, we were also starting the next steps at the same step at the next phase. And one of the clear things that was coming back from our partners who we commissioned was, by the time as an organization and for ourselves that we were getting the let's say the momentum in the right direction, we were already talking about kind of exit plans. So let's say from a 12-month contract, it would take a couple of months to settle in, to understand what the monitoring and the data that we required, and plus the other updates that we would need. There's a core section in there where the work will be done, and then in the latter part, we'll be kind of going through like the exit plans to kind of make some of the findings a little bit more sustainable. With those discussions that came out, we proposed having the deep engagement partner. Now, what this was a more structured 3-year relationship with communities that we've got, and it was broken up into into having 17 different partners where we've got, so 17 communities of identity, but with 14 community organizations, and they were split into kind of faith partners, disability partners, LGBTQ plus partner, the Blackshire communities that we've had, which is another project that which I've just mentioned, South Asian communities and other communities. So on the slides 25 and 26 that you'll probably see on screen, because I'm not utilizing that, you will see our partners who we've established, and some have been some of those community engagement partners that we had for the profiles. But we dug in a little bit deeper this time in terms of what our ask would be, because not just having, like I said earlier at the beginning, that some organizations have represented the community more broadly, but the challenge was to delve into the intersectionality of that community to get the real gold in terms for us to build up that relationship, because it has been that relationship that has come out core. We started from zero during COVID. We've built up this two-way intelligence with organizations and communities that we feel like a trusted member. So the program objectives of the deep engagement partner sort of fitted into 5 areas, and that was around the visibility, health literacy, the empowerment, policy change, and improving health. That was to kind of give the feeling that we weren't just a tokenistic point, that this was an opportunity to kind of influence the future of where public health will be going, and for us to for them to be linked into any future consultancy any consultations that's going out. So we have a mental health consultation that's been doing with our colleagues, and the deep engagement partners have been a real sort of a cog in that system to help getting this opportunity out within their community as well. But we kind of broke it down into a summary of outputs, what we were doing. So having 4 focus groups, and looking at a summary report, looking at some of the outcomes that they've done, from an engagement point of view, where they fall across the council in the forums. So we have a partnership of communities of identity, and so that gives an underpinning for this whole project, not just to kind of sit on its own, but it's actually having a little bit of a legacy within this. And the most important part of it is that we've got to kind of help upskill and train the community. So we have got a cultural intelligence program that's running with community researchers, but also where we have worked with the likes of BVSE to build in community leader workshops around that. And already at this early stage, we've seen some really quick wins around this, and especially at a time of austerity, we've got to demonstrate how this has been working constantly. So it is a big thing for our team to move forward with. So looking at kind of the recommendations and action, we put it into a table, so I kind of just glossed over it a little bit for you. But from the co-production, co-creation, so the future iterations that have come on, so currently we've updated quite a lot. I think there's about 14 that we've done, so for us to remain. We're going through it a little bit more in detail, but linking in with some of the deep engagement partners to have and potentially some of the lived experience that was in there. So making it a little bit whole, more from what the recommendations that had come out. Bringing in some of the actionable insights. So where we have got those gaps in data, are we able to create the scenarios or looking at targeted interventions or targeted engagement to get some more of that quality data through? The next sort of 2 are a little bit probably more of the challenge, so to speak. With the AI kind of journey exploding, there's an opportunity here to work with programmers or software to see whether we can get this in real time. So whether we kind of pick out a few selective themes within the profiles are we able to have kind of more of an interactive profile uh, dashboard in real time? So that is a real key goal that I personally wanted to see that, because when we did have discussions with politicians and where the profiles got to, and it did go to the number 10 at one stage with one of our providers. They were really keen of, how do we know what the data is today? How does it, because at the time we were using 2011 census data, we've updated it now. This is going to be a future challenge in terms of how we would do that. And the last one is quite simply, it's a challenge for everything. Put it through how we disseminate it out. Again, we need to do our part in making sure that it goes as far as wide. Those people who are on this call, making sure that they use it, because if you don't use it, you lose it. So this is the big thing, not just only for this, but as a council at a whole, to see how far we can get with our stakeholders around that. So at this point, I'm going to kind of bring it to a close in terms of this, just to say that for the deep engagement partners, it's sort of predominantly led by Lauren within the team, who's put a little bit more information in the chat for those who want to go into it. It's a new thing for us in terms of having a longer relationship with this side of it, and we are not the official sort of engagement arm of the council. We are there to help facilitate a lot of the health needs that come through, and sometimes it does, with the strength of the relationships, we are able to get a little bit more out of the partners, but they also have the request from us as well. So where we are able to help them, we've done that. This project is about empowering the communities, not being prescriptive in terms of saying this is what is good for you, could you please do it. It's giving information to communities and saying, what do you want to choose in order to do that? Now, some things can be duplicated in other areas, and we try and steer people away a little bit away from that side. And importantly, how do we get that engagement across the whole of Birmingham? Because sometimes communities you can focus in a particular area, but the need might be different in another part. So building in that equity. So we're on a journey in that. We will sort of stumble, but we will get there in the future. So I'll pass it over to, is it the Q&A at this point? If anybody's got any questions, then please do. I do have some of my team colleagues on the call, so if it gets a little bit too in detail, I might have to just pass over to them if they know a little bit more, but I should be able to kind of deal with it.
Thank you so much, Ricky, and bang on time as well in terms of timekeeping. We're right on the agenda. Thank you, and really interesting to hear those reflections on next steps as well. I think there's so much opportunity to bring these to other parts of the country as well, and to learn from what's worked here in Birmingham. So I'll open it up now for questions. If you would like to ask a question, please pop it in the chat, or you can raise your hand and Martin will allow you to unmute yourself. So please, any questions about the profiles, the research, or their dissemination? So we have a question from Gabriella. Gabriella, are you able to unmute yourself, or would you like me to read out the question? And Martin, you can give Gabriella the opportunity to unmute.
I think we probably, okay.
Now you're able to unmute yourself.
Hello, everyone. Thank you so much. Really useful conversations, lovely presentation, and so much to take on. I'm a community outreach officer in London, Northwest London, working public health, working exclusively reducing inequalities among the Portuguese speakers. In Brent, we are more than 40,000 at the moment. And yes, I resonate with every single information that you provided and your findings, and even the intervention and approach to engagement. My question is, how did you address during the research language as a barrier? What did you put in place in order to make sure that you have representatives of all ethnicities, making sure they felt comfortable coming forward and sharing their views and empowering the future? Thank you so much. Thank you.
Thank you, Gabriella. Oh, is it the research or the innovation? Perhaps you can talk about the innovation, Ricky, to make sure with the CHPs that they were accessible. And then Layla, you can come in and talk about the research, if that's okay.
Yeah, that's fine. I remember a colleague of my a colleague in the team now, Jordan, who he kind of said, "Rick, how do we pick which language do we choose?" So it's quite useful, that question. So at the time of when we were to put it together, there was something like 108 plus different communities of identity within the city. Plus, I think it was over 126 different languages that were being spoke. So a lot of the discussions in terms of which language that we choose were down to sort of finance, if we're being completely honest. What we looked at was the top 15 different languages that were being spoken in the city, and we were able to sort of translate those. And that came from a bit of legacy from COVID when we were putting our health information out. Now, what we did have was understanding culturally that in some communities, having written word down is always not the best way. So within the Chinese community, what platforms were being used? Were we using sort of traditional Mandarin, or was there kind of a different version that was out? Within the Somali community, there were different sort of language sort of several different languages within them. So what we did was we did sort of consult with some of the community to find out which one will probably get the most attention. And so if you have a look at the profiles, there is a translated version of one of those languages chosen. That is available. And then we did also do an infographic summarizing it in that chosen language. We also then did a webinar for it to be translated by from a voice and audio perspective around it. So we try to accommodate it the best we can, knowing that we were never going to be able to complete the full demand of that community. But again, one of the challenges is that does bring is cost. So yeah, I hope that's from our side of it. It kind of explains it.
Thanks, Ricky. And then over to you, Layla, to discuss this from the research side.
Hi, Gabriella. Thank you very much for your question. So we did the research aspect of it, trying to understand why people use it, why people don't use it, how we can best improve it. And we spoke to users, non-users, we spoke to policymakers, engagement partners, and writers. And all the people that we spoke to spoke English and did everything in English. So we didn't come to a point where we met someone or we approached anyone that was non-English speaking. So we didn't face that in data collection. Yeah, in our data collection. Yeah.
Thank you, Layla. And Gabriella, if you are interested in using them or creating community health profiles in your work, I'm more than happy, and I know Layla would be more than happy to have a discussion with you about that, if that would be helpful for you, because we're very keen for this practice to spread.
Thank you so much. Yes, absolutely. Thank you so much. Thank you.
Great. And Alexia, you mentioned in the chat that you'd been looking at the CHPs on the site, and you may have missed this, but how long has it taken to produce this volume of insight? Great question. There's clearly so much work that's gone into this. You're keen to apply a similar approach locally as well. The offer also extends to you. Perhaps, Ricky, you'd like to take this. How long did it take to put all this together?
Too long is probably the easiest. I think the original sort of per profile was looking around about 4 months per profile. But just to put it into context, that was while we were working simultaneously with different, so officers in the team were doing 2 or 3 at a time. These are 125-page documents, technical documents, very, very detailed. And that's why I was talking about the skill set that these guys in the team could take that anywhere. But and what they develop is brilliant, in terms of their knowledge and how they're able to do it. And that took time. So once we got the methodology in there was a methodology document that had been produced in terms of how to do your profile as a blueprint. So if any of the public health team wanted to use it, they could do that using that. And quite interestingly, neighbouring sort of councils within West Midlands, about 95% of the profiles will be exactly the same. The only difference would be the demography around it. So once we kind of worked those nuances and got a little bit more skilled, it did speed up. We did commission out the profiles for partners. It was up for tender to help write it, but ultimately we had to kind of standardize it and get it into the same kind of way. It was then checked by academics. So it was a rolling program of probably around about 2 years, I would say, that for all 25 to be done. However, it hasn't stopped because we are going back to update it with the new census data that's been released.
Really helpful, Ricky. Interesting about those academic checks. As an academic myself, I was dismayed to read in the data that it seemed like the academics checks were less useful than perhaps some of the other checks, if I'm not mistaken, Layla. Did that come up as a finding? Yes, it was.
Yes,
and so
it
I think that's just the importance of, being broad in the range of stakeholders involved, and perhaps academics aren't useful for checks, but they can do other things. And it's great to hear as well about that blueprint that you mentioned, Ricky, that really helped the innovation to spread. How important to have that initial template that can be built upon, so you can do that desk research initially, and then kind of add to that. It seems like it's really important for scaling this. Jordan, I don't know if you are able to unmute yourself. Maybe Martin, you could unmute Jordan, because you have a really important point in there about supporting people who'd like to create community health profiles themselves. So Jordan, I think you're able to unmute. Yeah, hello.
Yeah, I can unmute. Sorry, I'm full of cold, so there's no cameras. But yeah, I thought it'd be useful to share that if there was, we've got a couple of resources that we've kind of reshared a couple of times that have been quite useful for people learning a bit more about the in-depth of the profile. So the video that I just shared goes into a bit more detail on like the journal searches that were conducted, like the Ovid specific research terms, the key data sources. It includes like a complete research kind of flow diagram to show kind of how many papers were included overall. So that kind of gives people a good start point to understand kind of the process and kind of how things were developed for the more recent profiles.
Thank you. Hopefully that'll be useful to others who are interested in creating community health profiles in their own area. I mean, these health profiles have been around for a very long time, and they're used in a number of different countries. But as Ricky mentioned, it seems like these health profiles, at least in the number of communities that have been created, is very unique to Birmingham. And it would be very interesting to see how other places approach this as well, in the communities of interest there. Other questions? No, in that case, just a huge thank you to everyone for coming along to listen to this. We really, really appreciate your participation in the evaluation. Thank you very much to the council for commissioning the evaluation. Layla, did you want to come in with some final words?
Yes, I just want to say thank you very much to all the people that I have spoken to as part of this research data collection on call here. Thank you for your time and your willingness. And I was so surprised because sometimes it's difficult to speak to some people, but you're also quick to give me your time to talk about it. And I think all of you were passionate about this project, as in the community health profile seems to be something that you are all passionate about, and we all want to work towards it, to making it something bigger, useful to Birmingham, but then useful to the whole of the UK and beyond as well. So thank you very much for your time and your contribution in making this community health profile better. Thank you.
Thank you, everyone. Take care. Have a lovely day. Bye-bye.
Bye, thank you.